Morning. I'm so happy to be here, and I am not a nurse, but an ally, as they say, and so excited to be here. I don't think Sue mentioned before that the first nursing report was the most downloaded report in the history of the Institute of Medicine. Can't hear me? Oh, can you hear me now? Okay, so the first nursing report was the most downloaded in the history of the Institute of Medicine. And based on what I've prepared for today, I know this next one will even be more so, because I think it's going to have an impact. It had a great impact on nursing, but I have a feeling this next one's going to have a great impact on the rest of the professions and the fields who are addressing social determinants. So that's why I'm so excited to be here today to contribute. And thank you to my fellow panelists for really teeing this up well. So some of you have seen this, and our Commissioner for Public Health was just in the room and probably had to leave. She has quite a busy job, Dr. Morita. But she showed this yesterday, and this came out of one of our colleagues, David Ansel, his book called The Death Gap. And if you look at downtown Chicago, where some of you have probably been, our magnificent miles, shopping, that sort of thing, our life expectancy is 85. If you go a little further west, and we're probably just a little right of the 72 mark, but you see how the life expectancy goes down tremendously and then picks up again when we hit the suburbs. So what does this mean? This basically means the incredible value of what we're discussing today and what the panel and the committee and the report will focus on. There's a 16-year difference, 16 years. And, what does it say about social determinants? What does it say about equity and disparity, whatever you want to call it? We have huge issues to address, both socially, at the individual level, and structurally, to get to the root causes. So we know this has an incredible impact on patients, families, and communities. And this is why many of us are calling social determinants the new vital sign. So why are there these disparities? Well, in order to promote health equity, we need to understand what influences health outcomes and contributes to the disparities we see. When we dig into it, we see that multiple and complex factors contribute to inequitable outcomes. So we need diverse disciplines and perspectives to understand the pathways and design interventions. Collaborative research is really about more than one discipline focusing on research. Now, as far as I'm concerned, none of us have enough health service researchers out there, so that would be a big takeaway point for me today if we could address that at some point in the future. But professions engage, we all try to engage in our scientific inquiry, but we don't often do it together. And we don't often do it by looking at not just a specific area, but what our roles are in that area. So that'll be a big theme of mine today. So an example of all of this is where nurses, I was supposed to have another little thing pop up. Can I go back somehow?
Right there next to the green.
There we go. I don't know why it didn't work, but this is an example here about breast cancer disparities that help describe the different ways that researchers can study links between social and psychological factors in gene activity. Answering that type of research question begs for an interdisciplinary team yet again. So this is probably something that you supported, Ann, right? With some of my social work colleagues up there, too. So I also want to just talk about this next slide, that it's important to note that other sectors, particularly public health, as Sue mentioned before, as well as my field of social work, have really spent a lot of time over the years looking at social determinants. And again, if we look at them together and from more of a public health lens, we're certainly going to make more of a difference than just trying to address one determinant at a time. We say this, Janice and I, a lot at Rush when we're developing programs. And it's important to make sure someone has food on their table. It's critical. It is about health as well. But then how do you figure out what to do with the greater area and address that community? And we can't do it. It's not just about other disciplines. we have to do it with our community partners. We have to address these needs because they know what's best. They're much closer to the reality than we are, particularly those of us in more academic settings. Funny that I should mention the practical playbook too. Multi-sector partnerships can help health systems be more responsive to true population and public health needs. This practical playbook uses the concept of socially accountable health systems. Have people heard that term? I really like it, and particularly attending to academic medical centers. And it basically says we need to adapt education and training to look at their community's needs, define institutional objectives together with society, contextualize educational programs to improve local health outcomes, focus evaluations on impact, and have partners assess program success. Even those partners who are in the community, they are critical to determine our success, critical. And that we have to support students to become change agents, which is very close to what their vision for the future was a few minutes ago. So there are many activities underway across the country in this direction. Ann mentioned many of them. And there are programs that include roles for social workers, community health workers, pharmacists, and social determinants. There needs to be a little more in nursing, clearly. I looked and found a few things, but all of us have a few things, all the disciplines. And part of what the future should be is connecting all the dots and the disciplines with the community and studying it together and even showing a greater impact and need. So most communities are taking on equity-focused initiatives. Some of the anchor mission activities going on. We even have an equity dashboard as part of our quality metrics at Rush, thanks to our leadership over on my left, to monitor disparities and to even reflect for physicians and nurses, hopefully, how they're doing on that equity dashboard. So all of that is going to be totally critical to move the dial. So, of course, it takes a team. And going back to Wagner's work a while ago that I think is still critical, the chronic care model, that it really is about integrating social and health care. And the most successful chronic illness interventions include major roles for non-physicians. Don't you love that term? But he said it. I'm quoting him. For instance, delegating responsibility for key tasks in chronic illness care to quote-unquote non-physician team members increase the likelihood of task completion. How do you like that? And that effective team care for chronic illness often involves professionals outside the group of individuals working in a single practice. Not surprised. But it's good that years later, we're still not quite, it's not good, but years later, we're not quite there, but I think this report will make a difference in hoping to address that somehow. And to assure effective clinical and behavioral management, practice teams must have the necessary expertise, information, and resources to act rather than simply react. Thus, we must design and create processes that promote what he called productive interactions. And no one has really studied those productive interactions. The Nexus Center out of the University of Minnesota, funded by HRSA and the John A. Hartford Foundation, is a place that a lot of interprofessional work is going on, and even when you look at their research portfolio in this area, it's pretty slim. So the roles of team members should be clearly defined and explicitly delegated, and team members should be trained around their roles. And more than anything, I think for us is a notion of a shared leadership model when it comes to team, that when you talk to physicians, it's often physicians who feel like the buck stops with them. And I think if we could change that in our new culture of health, I think it would make a huge difference for the patients and the populations we care for. So if you look at this study, it was pretty interesting. There's an increasing amount of health systems that know identifying social determinants, and not a day goes by where I don't hear another thing and another plan. It's one thing to address and identify, it's one thing to identify needs, but more importantly is we need to address the needs from a person-centered approach. One survey, this one, of physicians, pharmacists, and nurses and social workers, it was from a large integrated system in California, asked them their opinions about screening for and addressing social needs. And that group said that social needs were an issue for most of their patients, that they were aware of resources to address these needs, more so than the physicians. This is like a little, I hate when these guild things go on, but this was a little debate here which shows the importance of involving the whole team. And that this group was more confident in their ability to address the social needs. And that the non-physician respondents were also more likely to endorse concerns that patients may feel uncomfortable answering questions and having greater empathy toward this whole area, because who asks the questions and how the questions are asked are absolutely critical. And when we think we can throw this on anybody and everybody, I think we are wrong. We need to, we all have wonderful people working around us, but they all need to understand how best to do this. But we know that nurses, you can play a critical role, and you have a large presence in healthcare settings in the health system, and in some ways have a greater leverage because I think you're more understood. That's why you have so many people signing up to be in your college, Pam, because you're very much understood by the masses what a nurse does. It's a little harder for social workers, community health workers, those of us, others on the team, pharmacists, to get the world to understand what we can contribute. So you're one step ahead in many ways. So here's a little, nurses have a long history of community engagement. We know that to address social determinants of health. Consider your pioneer, Florence Nightingale, who used epidemiological skills and scientific knowledge to improve hygiene conditions. Or Lillian Wald, who coined the term public health nursing, that nurses were responsible for addressing social and economic problems. Today we know that nurses engage with patients and help improve the system in diverse points of entry, critical points, whether it be the emergency room, the inpatient stay, the ambulatory side, or the community. You are in critical places where are moments of opportunity to help people look at their health more broadly as they need to be in order to improve it, which is, of course, addressing those social determinants. In this study, it was found that home visitation interventions by nurses could provide an effective means for mitigating social determinants of health by empowering people at risk for health disparities to avoid injury, maintain health, and prevent and manage existing disease. So I thought that was an important one. We've done some amazing work at Rush, my colleague Janice Phillips over there leading it, and Angelique, our Chief Nursing Officer, Angelique Richards, raise your hand, to survey our nurses, because we wanted to bring nurses to the table in making sure they are playing a major role in social determinants, which they are, but this made it a little more official. And we screened 449 nurses and found out some very interesting things in getting them ready to take on more social determinant work within their current workloads. And they cited the top reported barriers were, in thinking about taking this on, was believing that social work or case management handles these types of issues, that nurses reporting not knowing how to address the issues if they were present, that was before, now they're feeling a little differently, and that they're worried about patients being uncomfortable with the questions. So I have to tell you, I saw some data just the other day that shows that we're screening in the outpatient settings. Nurses are not playing a critical role there at our main campus. In our outer campus they are, and some of them are in the audience. And the emergency department, 20% of people are being screened. And in the inpatient setting, 65% of our patients are being screened for social determinants. 65. And why is that? Well, I think it's because nurses are involved and we've baked it into the process. So basically, I think you've gotten my point that it takes a team, but role clarity is a critical part of that. And, what are all the different things we do? And we know that if we got our roles clear and we understood what each of us did a little better, we would be able to advance and address the quadruple aim and all the things we do. So let me just quickly show you one more thing, which is our Triad approach to care management. We're using social workers, nurses, and patient care navigators. And to just tell you, I saw, as I saw 3 of them walking toward me yesterday, and I said, all the team, the Triad, and I said, where are you going? And they said, oh, we're going to see a patient. And the clinician in me said, oh, that's great. You're going to see the patient, patient together. The administrator in me said, gee, does it really take 3 of you to do that? So I'm going to leave you with this and basically say, we have to prove our case to people who sometimes wear their admin hat like I did at that moment, knowing full well my clinical heart was with them. And how do we figure out how to best know what the nurse should do, the social worker should do, and the patient navigator, and all the other disciplines to make sense of what we're doing, how do we move forward, and how do we address our impact in studying what we do. So thank you.